This is going to be Chapter 10, Understanding EKGs, and this is going to be introducing ventricular rhythms. Objectives. Discuss the origin of ventricular rhythms. Review specific components of the electrical conduction system of the heart. Identify premature ventricular contractions, including EKG characteristics. Identify idioventricular rhythms, including EKG characteristics. Differentiate idioventricular rhythms and accelerated idioventricular rhythm. Identify ventricular tachycardia, including EKG characteristics. Identify ventricular fibrillation, including EKG characteristics. Identify ventricular asystole, including EKG characteristics. Discuss pulseless electrical activity, and discuss the clinical significance of ventricular dysrhythmias, or rhythms. Origin of ventricular rhythms. The rhythms are classified according to the heart structure in which they begin or their site of origin. The sinoatrial node or the atrioventricular junction tissue fails to generate an impulse, and if you'll notice in the last two slides we've said it's like we keep adding a section. In the junctional slides we said the sinoatrial node fails to generate a beat, then the AV node takes over. In this case here, if the SA node and the AV node fail to generate a beat, then the ventricular area will take over as well. If this failure develops, the ventricles will assume the role of pacing the heart. This is our last pacemaker site. Rhythms that are initiated in the area of the ventricular are called ventricular rhythms. Ventricular rhythms are the least efficient of the heart's pacemakers. You should recall that patient assessment is the most important indicator of clinical significance. Components of the electrical conduction system of the heart. Now again, we've reviewed this each time. Electrical impulses originate in the sinoatrial node, travels through the atria via the internodal pathways, and then arrives at the AV node, which you have a brief pause. And then it goes into the bundle of His, down the left and right bundle branches, and into the Purkinje fibers, into the ventricular musculature. So this all starts off at the sinoatrial node. It goes across the interatrial pathways, hits the AV node, gets to the bundle of His, into the right and the left bundle branches, into the Purkinje fibers, which actually stimulate the electrical impulse to the muscle tissue itself. And each one of these has an intrinsic rate. 60 to 100 beats per minute, 40 to 60, and then the ventricular muscle itself is 20 to 40. Again, we have electrical conduction system and their firing rate. The sinoatrial node is 60 to 100 beats per minute. The atrioventricular node, which is a backup system for the SA node, is 40 to 60 beats per minute. And the Purkinje network, or the ventricular muscle, is 20 to 40 beats per minute, and it is the last backup system that you have in your heart as far as pacemaker sites. This is your primary pacemaker site, which is the sinoatrial node. This is your secondary pacemaker site, which is the atrioventricular node, and this is, last but not least, the last site that we have, which is the Purkinje network, or in the ventricular muscle itself. Each one of them has intrinsic rates. The SA node has an intrinsic rate 60 to 100 beats per minute. The AV node has an intrinsic rate 40 to 60 beats per minute. And the ventricular muscle, or the Purkinje network, has an intrinsic rate of 20 to 40 beats per minute. Origin of ventricular rhythms. Impulses that are ventricular in origin begin in the lower ventricular musculature. Impulses may travel in retrograde or backwards direction to depolarize the atria. Impulses may travel antegrade or forward to depolarize the ventricles. Either way, the normal conduction pathway is bypassed. Due to bypass, ventricular rhythms will display QRS complexes that are wide, or greater than 0.12 seconds, and bizarre in appearance. Absence of P waves because they are hidden or buried in the QRS complex. Remember, the QRS complexes of most supraventricular rhythms are commonly less than 0.12 in duration. Premature ventricular complexes. individual complexes rather than an actual rhythm. A single ectopic out-of-place complex that occurs earlier than the next expected complex arises from an irritable site in the ventricles. Significance of a PVC is based entirely upon the patient's condition. Underlying cadence of the SA node is not interrupted by a PVC, nor is SA node depolarized. The PVC is usually followed by a compensatory pause. Presence of a compensatory pause coupled with wide bizarre and premature QRS complexes are highly suggestive indicators of a PVC. These things are going to look wide and bizarre, so whenever we're identifying these things, if we could look at the QRS width of these things, it's huge. It is definitely greater than 0.12 seconds, or 3 small boxes. All of the rest of the beats, which have a P wave, a Q wave, an R wave, an S wave, and a ST segment, and a T wave here, all of these are identifiable. This thing here is a funny looking beat, and we consider that it's wide because, or we consider that it's from the ventricles because it's so wide. It is greater than 0.12, so it has to be out of the pathways. It has to be coming from the ventricular muscle. Premature complexes, contractions. PVCs may fall between two sinus beats without interfering with the rhythm. This is referred to as an interpolated beat. PVCs appear in many different patterns and shapes. The morphology or shape of the PVC is based on the site of origin of the ectopic focus. So what that means is the way that it looks and its shape is based upon where it came from in the heart, and that its ectopic focus. PVC pattern and occurrence. Now, whenever we see them coming frequently, we're going to use that pattern verbiage that we learned back whenever we were looking at PACs. So, bigeminy means every other beat. Bigeminy means every other beat. Trigeminy, tri meaning third, means every third beat. Quadrigeminy, quad meaning 4, means every fourth beat. A couplet is two PVCs occurring together without a normal complex in between. So in a couplet you would see two of them in succession, one after another. And a run of V-tac, 3 or more PVCs in a row. So if you have 3 PVCs in a row, this is considered a run of V-tac, or more of them. This would all be considered a run of V-tac. So 3 or more is considered a run of V-tac. So identifying a PVC. Again, we're going to look at the 5-step process. So the rate. And the rate is going to be dependent on the underlying rhythm and how many PVCs you have. If you have them just occasionally, to where there's one, then it isn't going to adjust the rate so much. But if you're having the PVCs every other beat, that will adjust the rate greatly, especially if they are not perfused or do not produce a pulse. Second question is, what is a rhythm? Occasionally irregular, regular if it's interpolated. If it has every other beat, then that would be regularly irregular. Or if the patient was in bigeminy, the rhythm would be regularly irregular. 3, is there a P wave before every QRS? And for the PVC, there's no P wave before the QRS. And is the P wave Puru? And that's because in the PVC, when you're identifying it, the P waves of the underlying rhythm may be present, but other than that, the PVC will have no P wave. What do the QRS complexes look like? And they're usually wide and bizarre. When we're identifying a PVC, we are going to identify it that it's equal to or greater than 0.12 seconds or 3 small boxes. They're not hard to spot on this 6-second strip, and if they're not perfused, then your underlying rhythm or your rate, 1, 2, 3, 4, 5, 6, is going to be 60 beats per minute. However, when treating a patient that is having PVCs, the underlying rhythm in this, or the underlying rate, is really, since all of these are regular, and these look just as regular and about the same spaces in between the R-to-R intervals. This one right here, 300, 150, 100, the rate is greater than 75 beats per minute. So this patient's underlying rhythm is a sinus rhythm at about 75 beats per minute, even though by the 6-second strip method he's only perfusing 60 beats per minute. This person is having unifocal, and what that means is they're coming from one location. So this one here and this one here look very similar, or they look like they at least came from the same real estate. Sinus rhythm with unifocal PVCs. This here is a sinus rhythm with multifocal PVCs, and let's map it out. 5-step process. Step 1, we're looking at the rate. 1, 2, 3, 4, 5. But if we come back and look in the rate, 300, 150, 100, greater than 75, less than 100, if we use the R-to-R method on this, the rate's a lot faster than we're actually seeing. The ectopic beats are actually taking over perfusion. If they're not perfused, then that might be a problem in this patient. They may not have enough cardiac output. When we're looking at the PVCs themselves, again, they're going to be wide and bizarre. They're going to be greater than 0.12. None of these have a P wave. And if we look at them individually, these don't exactly look the same, which makes this more problematic. Each one of these came from a different section of myocardium. So each one of these together make the diagnosis on this multifocal. It comes from multiple focal points, or multifocal. So this strip is called a sinus rhythm with multifocal PVCs. PVCs are often indicate myocardial irritability, or the heart is just upset. It has the ability to become excited. It has excitability in its nature. Multifocal PVCs are more serious than the unifocals because they're coming from multiple locations, and that means that you have multiple spots in the myocardium that are irritable. Salvos are runs of ventricular tachycardia. Any indication of increasing myocardial irritability dictates that the patient be carefully evaluated and managed. If you have malignant types of PVCs, you may need to correct them with an antidysrhythmic. This here is ventricular bigeminy with a couplet PVC, and we're going to go through the 5-step process for this. 1 is rate. So if these are not perfused, then these here are your only thing that will generate a rate, which the rate, if the PVCs are not perfused, is at 40 beats per minute. Step 2 on this is what's the actual rhythm, and this is pretty regular. I would say that we are regularly irregular. This right here, if it was consistent and kept occurring, is a couplet. Step 3 in this are their P waves, and there are P waves for the ones that are generated through the QRS or the normal conduction. This is a T wave. The QRS, though, does not have a P wave on it. Or the PVCs do not have a P wave on it, and are wide and bizarre. So, step 3 in this, Puru, and there are for the perfused beats, or the ones that have the check mark on it, or the ones that run through the normal conduction system. QRS. The QRSs are normal on the ones that I have checked. They are wide and bizarre on the PVCs. Whenever looking up at this heart, what should have occurred, SA node fired, went across the atria, AV node fired, at the bundle, and if you'll notice, there's a little pace or ectopic point there, and there's an ectopic point there. Went down the left and right bundle branches to the Purkinje system, but what happened was something failed. The heart was hypoxic, it was irritable. These two pacemaker sites, the two stars, have kicked off their own beat. They're taking the stance that the body or the pacemaker sites in the heart can no longer control the rate of the heart or the rhythm of the heart. So I'm going to add my 2 cents in. And this can easily get us off the sheet of music that we need to be on, which is a nice rhythmic cardiac muscle. This is ventricular bigeminy. The reason it's bigeminy is we have a normal beat here, and then we have a PVC. Normal beat, PVC, normal beat, PVC, and PVC up here. Now, each one of these, A, and A, all came from about the same location. This guy here came from a different spot. And every other beat is a PVC. So this would be sinus rhythm with multifocal ventricular bigeminy, because it's coming from more than one side. This is considered ventricular trigeminy. Every third beat is a PVC. PVC, we identify them again by their wide, bizarre nature, and no P wave. Every third beat, ventricular trigeminy. Idioventricular rhythms, also termed ventricular escape rhythms, considered a last-ditch effort of the ventricles to try to prevent cardiac standstill. Means the SA node and the AB node have failed, and the rate usually is less than 40 beats per minute, and cardiac output is usually compromised with this. There's no atrial kick. You've lost 30% of your cardiac output. You only have passive filling occurring in the ventricles, and then the ventricles are off their sheet of music and kind of doing their own thing. An agonal rhythm. An agonal rhythm is when the idioventricular rhythm falls below 20 beats per minute. This would be their intrinsic rate. So if it falls below 20 beats per minute, we're going to consider that the rhythm is agonal. Frequently may be seen as the last ordered semblance of a heart rhythm, where either resuscitation is unsuccessful or after successful defibrillation, we may actually see an agonal rhythm. Idioventricular rhythms causes includes extensive myocardial damage, secondary to acute myocardial infarction, or failure of higher pacemakers. It is considered a lethal rhythm, and treatment must be immediate and aggressive. You need to jump on this. You probably have very, very poor perfusion with an idioventricular rhythm. So, idioventricular rhythms, 5-step process. The first one is rate, and the rate is going to take over the intrinsic rate of the ventricles, which is at 20 to 40 beats per minute or less. The second one, what is the rhythm? And if it is run from the ventricles, there is no atrial rhythm or distinguishable P waves, and the ventricular rhythm is usually pretty regular, but it's going to be very slow at 20 to 40 beats per minute. Step 3 in this, is there P waves present? And the answer is no, there's not. And step 4 in this is there a PR interval? And the answer is, since there's no P wave, there is no PR interval. And step 5, do all the QRSs look alike? And the answer is yes, they do, but they are bizarre. They're as wide can be. You can drive a bus through them. And the length of the QRSs is going to be greater than 0.12 seconds or 3 small boxes. An accelerated idioventricular rhythm may occur when the rate of the ectopic pacemaker, or the weird ectopic beat, or the weird site that the beat's coming from, exceeds 40 beats per minute. Commonly accepted rate is 40 to 100 beats per minute. There are no P waves or PR intervals noted. And this right here is an accelerated idioventricular rhythm. It is accelerated because it is running at 60 beats per minute, which exceeds the 20 to 40 that should be coming from that pacemaker site. So that's why we call it an accelerated idioventricular rhythm. May occur in conjunction with myocardial ischemia, can be mistaken for ventricular tachycardia. Imperative that you remember to always assess and treat the patient rather than the monitor or the EKG strip in an accelerated idioventricular rhythm. This rhythm is one in which 3 or more PVCs arise in sequence at a rate greater than 100 beats per minute, and this one up here is going to be VTAC. We've changed rhythms. This rhythm commonly overrides the normal pacemakers of the heart, often occurs rapidly, and is initiated by a PVC or by PVCs occurring in rapid succession. If the rhythm is sustained, patient's clinical condition may rapidly deteriorate. A sustained rhythm is one that lasts for more than 30 seconds. Again, a sustained rhythm is one that lasts for more than 30 seconds. If lasts for less than 30 seconds, it is a non-sustained rhythm or simply a run of VTAC. So less than 30, a run of VTAC. Greater than 30, sustained VTAC. And ventricular tachycardia. The very simplest and easy answer on how to identify ventricular tachycardia is 2 things. 1, the rate 300, 150 is greater than 150 beats per minute. The second thing is that the QRS complexes are very wide, greater than 3 small boxes or 0.12, and it has the appearance of shark teeth when looking at VTAC from a basic EKG perspective. So a couple things here. Greater than 150, wide and bizarre, and it has the appearance of shark teeth is what VTAC looks like. It's classified based on assessment and the patient's clinical presentation as either pulseless VTAC, which we would treat like ventricular fibrillation, or VTAC with a pulse. Immediate treatment is based on the presence or the absence of a palpable pulse. Pulseless VTAC, immediately defibrillated. The treatment of VTAC with a pulse is based on the patient's clinical picture. If they are hemodynamically unstable, and we're going to identify this by a very low blood pressure, shortness of breath, altered LOC, immediate cardioversion is considered. If they are hemodynamically stable, which means they have a normal blood pressure, absence of chest pain, no notable change in mental status, drug intervention is appropriate. We cannot leave them in a life-threatening dysrhythmia. Causes may include non-VTAC, myocardial ischemia, hypoxia, electrolyte imbalances, increased anxiety or physical exertion, and underlying heart disease. VTAC rhythm. So what's the rate? Well, it's definitely going to be greater than 150. And this here says 100 to 250 beats per minute. We only treat VTAC that is greater than 150 beats per minute. And what is the rhythm? There is no atrial rhythm or none that's distinguishable. The ventricular rhythm is usually pretty regular in VTAC. Is there a P wave? P waves may be present or absent, not associated with the QRS complexes. We are completely outside the pathways and running off the ventricular muscle. What is the length of the PR interval? And there's none on step 4. And do the QRS complexes look alike? And the answer is yes, except for in torsades, and we'll talk about torsades here in a minute or two, which is polymorphic, meaning it's coming from many sites, and it looks a little different, or the QRS morphology is very, very bizarre. And is the length of the QRS complexes, the length on these things, or the width on them is going to be greater than 0.12 seconds. Torsades De Pointes. And this is similar to ventricular tachycardia. The morphology of the QRS complexes shows variation in width and shape, resembles a turning about or twisting motion along a baseline. It may result from hypokalemia, hypomagnesemia. Now this one here is our leading cause. Low magnesium levels is what generally gives us Torsades De Pointes or polymorphic VTAC. Tricyclic antidepressant drug overdose, use of antidysrhythmic drugs, or the combination of these in any given order. How we identify torsades is by its variability, and it has a wave-like fashion that continues again and again and again. It looks like shark teeth when inspecting it, and it's wide and bizarre. Any wave-like fashion that continues to do this again and again and again should be considered that it has some polymorphic tendency if the actual rhythm is wide and bizarre. Torsades De Pointes identified by its wave-like motion, and it's looking like shark teeth, wide and bizarre, and its polymorphic tendency. Finding and treating the underlying cause of the rhythm is essential. Magnesium is the pharmacological treatment of choice, and that's because the leading cause of torsades is going to be low magnesium levels. Key to recognizing torsades is the variation of QRS morphology or shape. Ventricular fibrillation is a fatal dysrhythmia. It's the most frequent initial rhythm occurrence in sudden cardiac arrest. Tends to occur in the initial hours following an acute myocardial infarction or sections of the myocardium that have died. Occurs as a result of multiple weak ectopic foci in the ventricles. So at this point here, every pacemaker site has failed. You're running off the ventricular muscle as a pacemaker site, but now due to the hypoxia, the decrease in the actual amplitude of the focal points is what gives you the fibrillation. Myocardial cells appear to quiver rather than to depolarize normally. No coordinated atrial or ventricular contraction, and no palpable pulse. Electrical impulses initiated by multiple ventricular sites. Impulses are not transmitted through the normal conduction pathways, and that's because everybody's kind of doing their own thing in the ventricles at this point, and it's just kind of quivering there. There's no cardiac output with this. Waveforms appear to be disorganized, rapid, irregular waves whose morphology varies vastly. No well-organized QRS complexes can be seen. Death will occur if immediate treatment is not established. And the number one thing that we can do in this is to shock them out of it. If they have been down for a while, please jump on them and do some chest compressions in a cab fashion. Ventricular fibrillation is classified in two different categories. It is either fine ventricular fibrillation, the ventricular fibrillation waves less than 3 millimeters of amplitude. So 3 small boxes high, they're less than 3 small boxes, is considered fine VFib. And coarse VFib, ventricular fibrillation waves with amplitudes greater than 3 millimeters. So they're greater than 3 boxes high. Coarse fib is generally more irregular than fine fib. Patient assessment is critical in that artifact or loose leads can resemble ventricular fibrillation. Treat the patient and not the monitor. Causes of VFib include acute MI, myocardial ischemia, drug toxicity or overdose, hypoxia, and other causes. If you have the leads on and your patient is talking to you and has a blood pressure and a pulse and you think that it's VFib, really recheck your monitor at that point. This does not perfuse a pulse, and your patient will go unresponsive when they go into this. So on the 5-step process, 1, what is the rate? And we cannot find a rate because it's chaotic and erratic. 2, what is the rhythm? And this is pretty much rapid and unorganized. Rhythm's not distinguishable. It's just quivering or fibrillation waves, large fibrillation waves at that. Is there a P wave before every QRS? The answer is no, there is not. What is the length of the PRR interval? I have no idea. Do all the QRS complexes look alike? There are no QRS complexes. There's only fibrillation waves. And what is the length of the QRS complexes? Again, kind of unknown. This is going to be fine VFib. The reason that it's fine VFib is it's less than 3 millimeters in height. And this is going to be coarse ventricular fibrillation. The reason that this is coarse is this is greater than 3 millimeters in height. Ventricular asystole The absence of all ventricular activity, also called cardiac standstill or asystole. Asystole is represented by a flat line and is the absence of all cardiac electrical activity. And your flat line will look like this. There is no electrical activity in the heart whatsoever when asystole is seen on the monitor. It may be difficult to distinguish asystole from fine VFib. You must always check two different leads to definitively identify asystole. Often follows unsuccessful resuscitation attempts, may be caused by massive myocardial infarction, cardiac trauma, ventricular aneurysm, and complete heart blocks. So for ventricular asystole, all of these are going to be absent. So what is the rate? There is no rate. What is the rhythm? I can't tell because there is no rhythm. Is there a P wave before every QRS? No. Is it PURU? No, because we can't find one. What is the length of the PR interval? There is no PR interval. Do all the QRS complexes look alike? It would be great if we had a QRS complex, but in the case of asystole, we do not. It's a nice flat line. So no QRS complexes and no width to the QRS complexes. No electrical activity. The question that should come to your mind, what has created this environment that the myocardial tissue in the heart cannot produce a cardiac output or an electrical beat? Pulseless electrical activity. Pulseless electrical activity is the absence of a palpable pulse and myocardial muscle activity with the presence of an organized electrical activity on the cardiac monitor. This represents a clinical condition. The patient is clinically dead despite some type of organized rhythm on the monitor. So a PEA, if you look at it, will look like, holy cow, that should be producing a good blood pressure and a pulse, but it isn't. Formerly termed electromechanical dissociation or EMD, the causes of PEA include profound hypovolemia, massive myocardial damage, ventricular rupture, pulmonary embolism, acidosis, cardiac tamponade, hypothermia, hyperthermia, drug overdose, hypokalemia, hyperkalemia, or tension pneumothorax. Now, whenever we get to ACLS, we're going to identify these to where they're easier to remember. You have two primary causes of PEA, and one of them is going to be a mechanical cause, and the other one is going to be electrophysiological causes. The acronym that I like to use is CHET for HDOA. CHET gives me my mechanical cause, and 4-HDOA gives me my electrophysiological cause. Clinical significance of ventricular dysrhythmias. A premature ventricular complex, little or no significance to the patient without a history of heart disease. May even relate that the patient's caffeine or stress have increased the palpitations. Cardiac output may be compromised if PVCs are frequent. Administer of oxygen may pretty much abate the PVCs or send them away. Idioventricular rhythm, majority are symptomatic. That's because it's running at 20 to 40 beats per minute. Due to a decreased heart rate, may develop decreased cardiac output, weakness, dizziness, hypotension, and an alteration in mental status. A thorough patient assessment is conducted to determine whether the rhythm is perfusing or not. Idioventricular rhythm. This concludes Chapter 10, Introduction to Ventricular Rhythms.